the scientific director of BodyScience. It's a comprehensive functional institute in Miami, Florida. She runs one of the most successful cellular medicine programs for neurodegenerative disease and autoimmunity. She also developed cellular strategy protocols, a set of treatments designed to target and improve cellular inefficiency and ALS and other cell-based disease. Please join me in welcoming Amy Jaramillo to the stage.
Our topic is, how do you accelerate repair? And very specifically, the group had asked that we discuss TV4, TA1, BPC, IGF1, and MGF. I know that everybody's having a little bit of a difficult time getting TA1 and TV4, so let's talk about that. Let's come up with a couple of alternatives as well. And so let's do three things. Let's start by taking a step back to the previous slide just to discuss what's involved in repairing cell. And then let's take a look at what are the three steps when you're talking about tissue repair or cellular repair. And then finally, let's partner the peptides up with that so we can kind of see where they fit into that whole algorithm. It's the bottom line, huh? So the question is, how do you see disease? So for some people, they see it from an organ point of view, right? As a specialist, you focus on that organ, your organ, kind of to the sometimes detriment of anything else. For some people, they focus on systems, right? So an endocrine system, as an example, a digestive tract or a digestive system. But at the core, we're not really talking, I don't think, about an organ or about a system or even about a tissue type. We're at the level of the cell, right? If you have strong cellular performance, mitochondrially, then you can reduce risk of disease and syndromes. Okay, so what we're talking about is, how do you engineer cellular function? Regardless of the condition that somebody has, regardless of the specialty that you want to focus on, the real question is, how are the cells functioning? Can you engineer better functionality? Okay, so the slide that we looked at last time, and just to walk through the steps one more time. So really what we're talking about is, how do you identify cellular inefficiency? What are the three steps that you want to take a look at as far as correcting it? So we know, number one, we talked at length earlier about the nutrients. Remember, whatever your patients are eating, whatever they're supplementing with, whatever you're using as far as supplementation IVs, that is what the cells are now going to use as substrates to drive their reactions. If the limitation is nutritionally, regardless of the peptides that you put on board, regardless of the growth or healing that you're looking for, the cells can't accomplish that. So you're always going to look first to nutrition and, as far as testing, to determine what is competing for those nutritional components. This is the time that you want to do it, right? So you can really acclimate the best possible ingredients. Okay, the second thing is, if you're trying to get tissue healing, right, because that's really what we're talking about, it's not a question of can you put a peptide on board. The question is, does the cell even have the infrastructure that it needs? So I leave my house in the morning, I decide I want to build a restaurant 10 miles away. If there really are no roads, who's coming to my restaurant? The answer is nobody, right? So on the cell side, it is no different. What we want to be focusing on is, how do we build organelles? If what we want is better mitochondrial function, the question is, how many peroxisomes do you have? And then lastly, once you have somebody and they've got lots of inflammation, the cells haven't been wired properly, you're going to have to correct that nuclear signaling. And so you're going to look to balance out oxidative stress versus antioxidants. Remember, oxidants are not a bad thing. Cells need to build, they need to tear down. So you never want to be so antioxidatively driven, right, that you can't get enough oxidative stress. The cell is going to toggle between those two. And so this becomes our cascade that we base everything off of a foundation. Going back to the topic, right, here's what we're talking about. How do we accelerate repair and immune response, right? Because ultimately that's what we're trying to do. And once we position the cell, now we're in a pretty good place to start doing that. So there really are the three steps. So if you think about it, right, it's between repair, controlling the lifespan, and immune regulation. So the repair part of things. What we're trying to do is exactly as you'd envision it. Accelerate wound healing, right? You're trying to get lots of blood supply over to that area, and you're trying to increase the ability of cells to move around and repair neighboring areas. Okay, everybody now should have kind of a red flag in their mind as well as far as balance, understanding that if you over actively repair, now you're going to wind up with something that you don't want, right? So some type of pathogenic condition, right? Cellular overgrowth. So there's a place for repair, and there's a limitation to the amount of repair that you want to do. Okay, cell lifespan. Here's the question. You want to be in apoptosis or you want to be in senescence? What do you guys say? Where do you want to be? Shout it out. Okay, what's the advantage of apoptosis? Totally. If a cell cannot become apoptotic, right, and it's not functioning properly, it's going to harvest all the energy from the neighboring cells, from the stem cells. It's going to cause all kinds of problems. So in a situation where you have a senescent cell that is not functioning, you want to move it towards apoptosis. Okay, and at the same time, do you want to move everything towards apoptosis? So in the world of neurology, for example, where neurons are hard to grow, they're slow to grow, do you want to just move anything that's inflamed over to apoptosis? No. So if you can recover it from a senescent standpoint, you may want to, depending on how damaged that cell is. But either way, from our vantage point, we want to kind of get a sense of how we want to control one versus the other. And then immune regulation. So immune regulation really is building versus breaking down. Remember, this is not just about building, because you can build to the detriment of the cell. And you can build to a point where you used up all the energy in the cell, and then the cell can't even maintain whatever was built. For me, because I live a lot in the world of neurobiology and neurodegeneration, do I want to build a bunch of muscle if I don't have synaptic ability to drive it? And the answer is no, right? So you want to build at the same rate that you can maintain. So you want to kind of go back and forth, toggle between oxidative versus antioxidant. So remember, none of these are good or bad. Okay? They're all within balance. And the question then is, from a balance point of view, how do you want to control them? How do you want to regulate them? And from that, let's take a look at peptides. All right, so the blue on the top, you guys know I don't do fancy slides. This is the extent of my slide ability that you're seeing right here. All right, the blue on the top, that is just revisiting what we just discussed, right? So we know already there's three things that must happen, and they're going to continue to go back and forth, right? They're happening kind of across a spectrum. So the cells continue to need repair. They continue to need to control their cell life cycle. There's some point where mitosis has created so much junk that you are going to have to move that cell out. But prior to that, instead, you want to preserve that cell life cycle. And then finally, again, the immune regulation behind the whole thing. Okay, so now if we take a look at the peptide perspective of this same conversation, here's what we're looking at. Let's look at re-educating the immune system. And so I know there was a conversation earlier in the day, I think Betsy was talking about TV4 and TA1. Let me ask, first of all, are these two peptides that most of you have familiarity with? Right, okay. TA1, about the safest peptide, right, even indicated for pediatrics. So we all know we can play easily with TA1, whether it's a sub-Q, whether it's an IV. What's the reason for TA1? What are we actually trying to do with it? Modulate. Why? Why do we even need to modulate? So what is it? Yeah, so here's the question. COVID is around now, okay, but how many of us actually have had exposure to COVID as youngsters, or have had thymus education for the T cells to understand when a new virus shows up, how to manage it? And so think about kind of where we are. I assume, right, the way evolution envisioned things, we're going to grow up until about 12, 15, right, create an immune system, have a lot of thymus gland involvement to educate primarily the T cells, and then continue to live a life around that same environment, with those same exposures, with those same toxins, with that same combination of infections, except that's no longer the case. And so in the absence of really having a robust thymus, what we have is T-cell dysfunction. And understandably, right, bodies coming in contact with all kinds of things. B cells making all kinds of antibodies, not even sure what they're making antibodies to sometimes, right? All these threats for a very limited number of tools. And so then roll in the T cells, and T cells are going to do one of two things, right? They're either going to help or they're going to destroy. So to modulate them, TA1 is a pretty nice, safe way to provide a degree of education to cells that have already passed an age where they would have gotten education for the kind of things that they're seeing. And so imagine for us at this point, it's so relevant, because think about the number of infectious agents that we're seeing now, and think about traveling pretty much anywhere outside of the zone that you live in, the kinds of things that you're going to see by comparison. And even viruses that have the same name. I deal with a lot of tick-borne disease, and so I don't know if a number of you do, but the long and short, Parvo-19 is a virus, and HHV6, it looks really different in the US as it does from other countries. And it has a way of doing something very unique when it comes to tick-borne disease, especially when Parvo-19 is coming from the Middle East. Okay. So what I'm saying is, again, where you get these infections has a lot to do with how your body's going to manage through them. And so as everybody's traveling all the time, can you regulate an immune system? Can you control a CD4, CD8? Can you control a Th1, Th2 humoral immunity? Can you control an immune system that is being bombarded with infinite amounts of infectious agents without having something there to help regulate what the thymus should do, which is educating that cell? And the answer is probably not. You're probably not going to get very far. So I like both of these peptides, and again, really what you're recreating is the educational opportunity that those cells would have had that person been exposed to those infections at a much younger age. Okay, control the immune system, right? So again, now we're looking at an immune system that is coming in contact with so many unknown scenarios. And so I like body protection compound. Who in the room is using it? Yeah, okay. Kind of like TA1, I find it to be easy to use, few if any side effects. The way that I use it has a lot to do with the kind of symptoms that I'm trying to treat. So for me, when I have somebody with ulcerative colitis or a bunch of GI-related issues, I'll almost always make it into a rectal suppository. If I have a lot of upper GI problems, I'll go PO. And if I just have overall generalized inflammation, at that point I'll go sub-Q. So remember, for all these medications, they can be made in multiple different ways. You're trying to get as close to the area of inflammation that you can. The reason for BPC, right, is because imagine if the first part is repair, controlling the life cycle, and immune regulation. As you're creating new cells, as you're doing wound healing, as example, repair, in a body that has confusion, immunologic confusion, there's a pretty high likelihood that you're not going to repair that area, you're going to attack that area, just by virtue of the replication that's going on over there. So I like BPC to just kind of tamp that down. I put over there low-dose naltrexone and sirolimus. I recognize they're not peptides. You know, again, the question is controlling the immune. So if what you want to do is heal tissue, then you know what you're going to have is a lot of cellular turnover. And cellular turnover for a body has a way, right, of really creating a lot of red flags. And so you're going to have the immune system very vigilant and very close by that area to try and get a sense of why so much cellular turnover is happening. As far as controlling the T cells, so to prevent T cell aggregation and damage to that area, I like the idea of low-dose naltrexone. And as far as mTOR, so controlling proliferation, and the signal that proliferation is going to give the rest of the body. In other words, lots of cells migrating around and growing, right? So usually bodies don't like that. And now you've got a body that has to differentiate what is healthy cellular turnover versus what is something that's building that shouldn't be, whether it's a cancer, whether it's a colony of yeast. So the body's going to take a look, the immune system's going to take a look and kind of get a sense. I like sirolimus just to control the mTOR side of things and proliferation. And the gut-brain barrier. So as far as BPC, I like it for that reason. I like the fact that we know that a body is one big body, right? We can agree to that. Again, diseases are happening in the cells. It's not like we're carving a body up and somehow the heart is doing something and the kidneys have no idea and then the liver is just there going, what? Instead, as far as the gut-brain barrier, remember, if inflammation is going to come from the intestines, as an example, let's say you're treating somebody and what they have is a lot of inflammatory stress in the intestines, You know already interleukin-wise, you're going to start to see 1, A and B, and that's going to trigger a signal in the liver, right? That's going to be interleukin 17. And now what you're going to wind up with is a signal that's going to kind of go to the brain and say, hey, something's going on over here, start protecting, and you're going to see antibodies to any number of things building up. So again, as far as gut-brain barrier and protecting the body from attacking when it shouldn't be, I like this combination. I like controlling T cells, regulating T cells in the direction that you want to regulate them, right? If what you want to CD8, then you want to build CD8. I use some light-based therapy in my office, so IVs with light-based therapies. There are times that what I want is a burn, right? What I want is an inflammatory cytokine mess, because I brought the inflammation essentially out of hiding, the infection, out of biofilm or out of the cyst. And what I want at that point, I want a body going full force towards it. So I'm going to use like a UVC light. And then by comparison, there's times that I want to heal the immune system. So then to that point, I'm going to use a different UV. I'm going to use an A or a B. And I'm going to use a different light source, like a red or a green. So just know, again, there's times that you want to modulate that. And then the rebuilding. So mechano growth factor and Moreland's, I'll tell you why I put them together. What we're really talking about here is how do you rebuild? So looking at the bottom, I mean, that's where reproductive hormones are coming in. So I recognize this is a conversation largely about peptides. It doesn't change the fact if there isn't a luteinizing hormone like testosterone or progesterone, if you're trying to rebuild tissue, but reproductive hormone isn't adequate, chances are you're not going to be able to do that. So for me, when I get to this point, if I'm looking at somebody and they are low testosterone, I'm going to address it for sure. The question is, how do you rebuild? If we're talking about muscle, I like mechano growth factor, right? If we're talking about neurons, I like things like dihexa or cerebrolysin. But just talking on the muscle side of things, you're going to need really a couple, outside of peptides, a couple things, right? The MGF is the peptide mechano growth factor. You could put PEG in there as well. You could mix in MK677, so now you've got muscle stem cells that are at your disposal. If you do not have enough human growth hormone, and you do not have enough testosterone, it is unlikely you will be able to grow tissue or build tissue. So that's why, kind of looking at this, you want to find your place for the reproductive hormones at the same time. All right. So now, just looking at this as a complete picture. Let me see what my next slide is. Okay, there you go. We know the top part is repairing the cell lifespan. I would tell you on the cell lifespan. I was just talking to somebody after the first conversation. Her question was specifically NAD and when I use it. And so what I would say is I oftentimes use NAD as a trick to figure out where I am in a cell life cycle. So whether I have a lot of senescent cells and where the location of those senescent cells are. So I'll use a really, really slow drip, right? And you can kind of tell if your folks that you're treating with NAD, they get that stomach ache right away, they get nauseous. For me, my goal is not to resolve the nausea. My goal instead is to slow down that drip and just kind of watch where does that go? Is it all lower GI? Is it coming up? Is it more esophagitis? What exactly is going on? Let's say instead they get kind of tacky, right? The next thing I'll look at is cardiovascular. Let's say they become disinhibited, right? Then you know at that point the senescent cells, the cells that are using up all this energy but not really producing, the ones that you're trying to move out, are more in the brain. So I like NAD for that reason. And then I think that's it. I don't think I have any other slides. Let me just see. Oh, yeah. I have 5 minutes. I'll answer any questions if you guys have them. Can I do that? Yeah, tell me.
So I'm curious, with I love peptide, I do a lot of peptide.
Yeah.
I've always kind of asked the question, if you're, let's say we're looking for a synthetic or a mitochondrial stimulator, and we're going to use, let's say, MONC, and
Okay.
0.1 cc aliquot we have MONC peptide. There's a finite number of peptide strands in there. Yet the theory of the story is that we're going to attack every mitochondria in the body, which is an infinite number.
Yeah, no.
The majority of synthetic cells, which can't happen.
Right.
And so I know they work, but we are not going to get every mitochondria, and we're not going to get every single living cell.
Right.
I know we go over a period of 5 days, maybe straight through for a month or so. But how do you reconcile that?
Okay, so again, for me, I'm one step before that, right? So the question is mitochondrial biogenesis. So we know that the mitochondria needs a couple things. We know that in order to get the electron transport chain, you have an intramitochondrial membrane, right? We know it's a lipid layer, so you know that that you're going to need a heat shock protein, and you know that you're going to need a chaperone to carry it across, right? So that's the kind of concept of bile acid and why bile acid is so critical when you're trying to get mitochondrial function. Between MOT-SC or SS31, my preference in that situation is probably going to be SS31. The question is, how well preserved is the electron in complex 3? I'm going to look at things like succinic acid to figure out the refill, right? So that's an easy test. LabCorp Quest, take a look at things like alpha-ketoglutarate, so before NAD, right? And right afterwards, succinic acid, how many electrons do you have back over there? Sometimes I'm even going to look at iron, since that's the electron transporter, and make sure that my ratio with things like copper and zinc are in line. So I'm never just going to take a peptide and throw it out there and hope that it's going to somehow repair mitochondria, because you're right, it's never going to look like that. The question is, could you kind of prep the cell ahead of time by putting everything in place, and then once you have mitochondrial optimization, then would MOT-SC be a reasonable next step? So for me, kind of in my approach, MOT-SC is down here, right? It's the place I want to be after my mitochondria are kind of doing what I want them to do. SS31 is kind of my step before that. Butyrate I have to do first, right? Because otherwise, again, I can't get the peroxisomes, and without peroxisomes, I can't get calcium, and I also can't get bile acid. Without bile acid, I can't get through the intramembrane in the mitochondria, so I can't get to the electron transport chain anyhow. So again, I like MOT-SC as far as a peptide. I use it, but I use it in my folks after I've worked through the inefficiency of the mitochondria. All right? That's my, okay.
I used GHK with copper healing. Is that also even in your?
The topic was very specific. I was given, I like GSK-CU. I use it frequently. I use it sub-Q. I use it IV because I work in a world of neurodegeneration, and copper peptides can be so useful in neuro recovery. What I would tell you is I'll always do iron testing ahead of time. I'll always make sure that my zinc is within ratio. But as far as a peptide for healing, recovery, I like the pro-neuron benefits that it has, and I like it in combination. I'll normally use it with a nootropic, so that and cerebrolysin for me is a great fit. If I'm going to do that, I'll almost always put in alpha-lipoic acid, right? What I want to do is really shield and protect neurons if we're talking along the neuron route. But yeah, GSK-CU is one of my favorites.
Do you cycle it? How long do you cycle it?
So I don't cycle a peptide. I cycle a process. You know what I'm saying? So then and oftentimes as I go through a cycle, when I come back around the second time, I'll change all my peptides. If I've already accomplished what I wanted to accomplish, and I've seen improvement, and I'll look for measurable improvements, right? And so if I've already seen that improvement, it's not likely I'll go back to that peptide. I know I've corrected that issue. So I'll continue to use that peptide for as long as I need to get through whatever that roadblock is. Once I've cleared that roadblock, then, kind of going back through, I don't want to go backwards, but if the next is repair, I'm back to repair again. So as I sequence through, I'm not really trying to be in GSKCU wound healing or tissue healing all the time. Otherwise, I risk overhealing, over antioxidative building without enough oxidative balance along with it. So again, for me, it's not so much a cycle based on a timetable. Instead, I like measurable outcomes. There's certain things I'm looking at for that individual, and then once I've already gotten there, I'm pretty much done with that peptide at that point. I'd like to, but I think we're done. I'm so sorry, but we can talk afterwards. Yeah? Okay. Hey, thanks.